Wonderful good day to everyone. My name is Oliver Senscheid and I'm today's moderator, and I welcome you to another part of the Euroimmune Educational Webinar Series. Our topic today is membranous nephropathies, antibody-based diagnosis, prognosis, and disease monitoring. And first, Dr. Beck is going to give a presentation on this very topic, which is then followed by a question and answering session. Please feel free to type your questions during the webinar in the chat box or after the webinar prior to the Q&A session so that I can read them to Dr. Beck. In case you signed up for PACE credits, please check your inbox, the email address that you used to register for this event. We will, shortly after the webinar, we will send you a survey which upon completion, we will send you a certificate for your PACE credits to the very same email address. So without further ado, I would like to introduce to you today's speakers, Dr. Beck. Dr. Beck is an associate professor in the Department of Medicine at Boston University Medical Center. He graduated from Harvard Medical School in 2000 with a dual degree in MD and PhD. He then completed his internal medicine residency and nephrology fellowship at the Boston Medical Center. Dr. Beck pursued a research fellowship in the laboratory of Dr. David Salon on the topic of membranous nephropathy. Together, Dr. Beck and Salon identified the major target antigen in adult idiopathic membranous nephropathy as the M-type phospholipase A2 receptor, short PLA2R, as reported in the New England Journal of Medicine in 2009. This report has stimulated a new wave of investigations into the pathogenesis of membranous nephropathy, as well as the clinical use of anti-PLA2R autoantibody testing for the diagnosis and monitoring of the disease. Dr. Beck and collaborators have more recently identified THSD7A as a second antigen in membranous nephropathy and LRP2 megalin as the target of anti-brush border disease. So with that, Dr. Beck, I thank you so very much for you being our speaker today. I'm very much looking forward to this webinar, and I'm opening up to you. Thank you so much.
All right. Thank you, Oliver, for the opportunity. The title of my talk today will be Membranous Nephropathy, Antibody-based Diagnosis, Prognosis, and Disease Monitoring. I'm going to break this into a brief introduction of the nephrotic syndrome and membranous nephropathy in general, and then I'll discuss how we came to discover these antibody-antigen systems in membranous nephropathy. I'll talk a brief bit about the utility of anti-PLA2R and anti-THSD7A for the diagnosis of membranous, and then move on to how we use it in terms of prognosis and the monitoring of disease activity by immunosurveillance or serologies. And then I'll have a few conclusion slides before moving on to a Q&A session. So for those of you who aren't nephrologists and aren't immediately familiar with the nephrotic versus nephritic syndromes, I want to briefly introduce these. Nephritis is generally an inflammation. So we have pyelonephritis, a bacterial infection of the kidneys. We have interstitial nephritis, which can be caused by drugs or medicines. And we have glomerulonephritis, which is an inflammation of the filter of the kidney, the glomerulus. On the other end of the spectrum, we have the nephrotic disorders and the nephrotic syndrome, which are largely marked by proteinuria and don't have inflammation such as red cells and white cells in the urine. So if you do a urine analysis in the nephrotic syndrome, you expect to find significant proteinuria, but few red blood cells or white blood cells. The nephrotic syndrome itself is a clinical syndrome that's due to a failure of the glomerular filtration barrier. And this is most often due to damage to a cell type called the visceral epithelial cell or podocyte. Clinically, what we see is patients leak large amounts of protein into the urine. And the only clinical manifestation that the patient may see, they may see some foaming or bubbling of the urine that's due to that excess protein, but they notice weight gain, they notice edema, swelling of the lower extremities, and sometimes the rest of the body if it gets severe. In looking at laboratory tests, patients with nephrotic syndrome have hypoalbuminemia, so low serum albumins. They have problems with hyperlipidemia and dyslipidemias. And those of us who like to look at the urine can find evidence of lipiduria, so lipid in the urine. These can be free fat bodies in casts that polarize to these Maltese cross pattern under polarized light, or you can have oval fat bodies either free or located in casts in the urine sediment. This is a transmission EM view of the glomerular filtration barrier. So we have these podocytes that have interdigitating foot processes that wrap around the glomerular capillary lumen. So the blood would be here, and normally the protein is reflected back and is not able to enter the urinary space because of these slit diaphragms between interdigitating foot processes. There are a number of injurious events that can occur to the podocyte in the kidney. These can be intrinsic stresses of the podocyte, such as genetic defects of the cytoskeleton or metabolic defects. We'll be talking about extrinsic stresses, such as antibodies that target the cell type. And all of these injurious processes can lead to a change in the phenotype of the podocyte, such that this very highly structured cytoskeletal organization that prevents the proteins from leaking from the blood into the urine becomes deranged, and the podocyte becomes simplified, the foot processes are lost, and protein can leak around the cell into the urine. Looking at this from a bird's eye view, this is a schematic of a normal podocyte, and you have these interdigitating foot processes, and between these little slits would be the nephrin-containing slit diaphragms that prevent protein from leaking. And when these cell types become injured and simplified, you have these abnormal junctions between the cells. There's no slit diaphragms here, so the protein can very easily leak around the cells and into the urine, and this is what causes the nephrotic disorders. So what's wrong with having a little protein in the urine? Generally, people don't become malnourished because of the protein they're losing, but there are a number of disorders that can occur. Because of the protein loss of coagulant factors and anticoagulant factors, the balance in the blood is shifted to a thrombotic state. So patients with nephrotic syndrome may have deep vein thromboses, renal vein thromboses, pulmonary embolisms. They can have the cosmetic problem of leg edema and swelling, but they can also have non-healing ulcers. There may be the high cholesterol levels and high lipid levels that can lead to downstream changes such as atherosclerosis. The loss of immunoglobulins and complement factors in the urine can lead to increased likelihood of getting infections. There may be vitamin D loss because vitamin D binding proteins are lost in the urine. But the most important thing that we worry about in proteinuria is that with sustained proteinuria, patients can progress to end-stage renal disease. And this was a graph made by the Toronto Glomerulonephritis Registry. These are patients with membranous nephropathy who either achieved a complete remission, achieved a partial remission, meaning that they had less than 3.5 grams of protein per day, or did not achieve a remission at all. And on the y-axis, we see the survival free from renal failure. So the patients who go into any sort of remission and reduce their proteinuria or eliminate it are the ones that have very good renal survival. The ones that don't have a remission and continue to have proteinuria for years are the ones that go on to have renal failure. So this is one of the main reasons we want to identify this problem and to treat it. When a patient comes to you with nephrotic syndrome with these clinical features, generally what we've done is a kidney biopsy. There haven't been a lot of good blood tests to identify which of these disorders the patient may have. And on biopsy, we see different patterns, and these are the primary causes of the nephrotic syndrome. We have FSGS, focal and segmental glomerular sclerosis. We have minimal change disease, MCD, and the topic of today's talk will be membranous nephropathy. The first two disorders tend to target a younger population, sometimes children, sometimes adolescents. Membranous nephropathy, although it can occur across the range of ages, has a median onset in the 50s. There can be other causes of nephrotic syndrome, amyloidosis, preeclampsia. Diabetic nephropathy can give nephrotic range proteinuria, but often doesn't have all the features of the nephrotic syndrome. So let's think about a prototypical case. I'm not going to give you the answer to this right now, but think about this case as we move ahead. So you're seeing a 56-year-old male in your clinic who complains of a 10-pound weight gain and the development of edema both in his ankles and lower legs. You do a dipstick in your office, and the urinalysis shows 4+ proteinuria with minimal blood or leukocyte esterase. The question is, what other tests would you consider sending at this point? So let's talk a little bit before we get on to what tests you might send to talk about primary or idiopathic membranous nephropathy. As I mentioned, it's a leading cause of the adult nephrotic syndrome with a typical onset in the 50s. Diagnosis has relied on kidney biopsy, and I'll show you some pictures of what the biopsy might look like. Distinguishing between the primary autoimmune form and secondary causes isn't always clear, and I'll give some guidance about what you might think about to distinguish the two. The vexing point for clinicians is that the course is variable, which often leads to difficult treatment decisions. About a third of the cases can go into a spontaneous remission if you wait long enough. Some patients are left with persistent proteinuria but stable renal function, and the concerning third are those that go on to progress to end-stage renal disease. And I would argue that measuring the amount of proteinuria that's lost in the urine is good, but it's a suboptimal measure of disease activity, and I think we now have better tests. So these images were taken by our renal pathologist, Joel Henderson, and show the basic features of membranous nephropathy. The disease membranous nephropathy is such named because the glomerular basement membranes are thickened. So in this PAS stain, you see these thickening of the wall of the glomerular capillary. If you do a special stain, the Jones methenamine silver stain, you can see these fine projections or spikes coming off the basement membrane. And you see these pits or craters where there's no silver staining. So this represents, the pits actually represent the immune deposits. And on IgG staining of the biopsy or complement staining, we see this fine peripheral capillary loop pattern of these deposits. So these don't stain with the silver. The spikes are actually the spikes of new basement membrane that are laid down by the podocyte around these deposits, perhaps trying to wall them off. So these are the pathognomonic features of membranous nephropathy that we look for on biopsy. The question is, what is in these deposits? And from animal models, which I'll briefly discuss, we know that there's immunoglobulin, generally IgG. There are complement factors, mostly C3. And we know there's antigen that's reactive with the IgG that's in the deposits. So I mentioned a rat model. The Hayman nephritis model of membranous nephropathy was actually developed in the late 1950s. It involves immunizing rats with a tubular brush border fraction of proteins. And it turned out that these rats got a disease that was very similar to human membranous nephropathy. They had immune complexes that were subepithelial, meaning right beneath the podocyte. There was IgG in the deposits, and there was complement factor 3 in the deposits. So this mimics almost exactly what we find in human disease, subepithelial deposits, IgG, and C3. Investigators went on and discovered what the target antigen was in the rat model of membranous nephropathy, and it turned out to be the brush border protein megalin. Investigators quickly looked in humans to see if megalin was the target in membranous nephropathy, and it turned out that it was not. So that led to the question, do humans have a target antigen that's targeted by circulating antibodies? And basically between the mid-1980s, when megalin was found to be the antigen, in 2009, we really had no idea if there were an antigen and what the identity of that antigen might be. So we and other labs set out to try to find the answer to that, and this work was done with David Salant, my research mentor and the chief of nephrology at Boston Medical Center and BU. And what we did was we took patient serum, patients who had membranous nephropathy and who had other diseases such as FSGS or diabetic nephropathy, and we used their serum and those of controls to see if there were any bands that could be detected by Western blotting using protein extracts from normal kidney, normal human glomeruli. And ultimately, after lots of work, we found that there was a consistent band, about 180 kilodaltons, that was recognized only by the serum of membranous nephropathy patients and not by other healthy controls or other patients with glomerular diseases. And the reason why we succeeded and perhaps others hadn't is that this protein is very sensitive. And if you do the standard gel electrophoresis and Western blotting technique, where you break the disulfide bonds in the protein, you lose reactivity of the human antibodies with the protein. So if you do it under non-reducing conditions, that's when we started to see this consistent band. And then we needed to figure out exactly what this particular protein was. So using the same technique, we've identified two different human podocyte proteins that serve as the target antigens that are attacked by circulating antibodies generated by the immune system in the disease membranous nephropathy. So you have this is the PLA2R protein, but shown in red in normal podocytes. You have circulating antibodies, and ultimately that antigen-antibody complex forms these peripheral capillary loop subepithelial deposits that I showed you in the pathology specimens. So these were published. The first was the PLA2R, the M-type phospholipase A2 receptor. This was published in 2009, identified in collaboration with our mass spectrometry experts at the University of Louisville. The second antigen was thrombospondin type 1 domain containing 7A, easier to remember perhaps as THSD7A. And this was done in conjunction with two groups, one from Hamburg, Germany, Nicolas Thomas, Rolf Stahl, and others, and Gerard Lambeau from Nice, also in conjunction with our Louisville mass spec collaborators. So both of these proteins, PLA2R and THSD7A, are podocyte proteins. They have large multi-domain extracellular domains that point out towards the glomerular basement membrane and the capillary lumen and have short cytoplasmic tails within the podocyte. PLA2R represents the major antigen. About 80% of all primary membranous nephropathy has antibodies to PLA2R. And THSD7A represents a minor antigen, maybe only 3 to 5% of all primary membranous nephropathy. So the general concept that I want you to remember is that there's a detectable circulating antibody that circulates in the bloodstream that percolates across the glomerular basement membrane and finds its target antigen, which is expressed by the glomerular podocyte. And over time, that antigen and antibody aggregate into large, long-lived immune deposits that contain IgG, complement factors, and the relevant antigen. So a schematic I put together shows this process. So you have these circulating antibodies that cross the glomerular basement membrane and find its target antigen, in this case PLA2R. And over time, there's either shedding of membrane or there's cleavage of the extracellular domain to form immune deposits, these subepithelial electron-dense deposits that contain the antigen PLA2R, the antibodies, and complement components. Complement goes on to activate the terminal complement cascade that leads to the insertion of C5b through 9. They form holes in the podocyte that let in calcium that leads to a lot of maladaptive signaling processes that ultimately lead to the change in phenotype of the podocyte and the loss of slit diaphragms leading to proteinuria. So I'd argue that we've entered a new era of membranous nephropathy. So prior to the publication and the identification of PLA2R, we largely took a clinical approach to following our patients, to monitoring them, and deciding whether they needed treatment. We followed protein in the urine, we followed their renal function, we asked if we could get them to either a complete remission or a partial remission. After 2009, when we have the ability to measure circulating antibodies to PLA2R, we can add a serologic approach to this clinical approach, following the antibody levels and trajectories. And I'd argue that this is a faster, at least, if not superior option of following disease activity in membranous nephropathy. So this is based on our initial work that had showed by Western blotting that Many patients with membranous nephropathy have antibodies that recognize PLA2R. Again, these are Western blots. And what we're looking at is the different subclasses of IgG. So the predominant subclass in many autoimmune diseases, including membranous nephropathy, is the IgG4 subclass. And we can see that many patients, their strongest band is an IgG4 anti-PLA2R. But they do have IgG1s, IgG3s, some IgG2. And similarly, in the cases of THSD7A associated membranous, there's often a strong IgG4 response to THSD7A, but also some other IgG1s. It may not come out too well in this slide. We can use that, and these were some initially published images, to stain a biopsy section. And this is a single slide that was stained for PLA2R, and the detecting antibody is in red, or the IgG4 subclass, and that's in green. And when you look at these under a wavelength where you can see both wavelengths, the two colors merge to form yellow. So the antigen PLA2R and the antibody IgG4 in this case are in the same location in the deposits. And renal pathologists have capitalized on this, and now they can, in addition to their standard stains of IgGs, IgA, IgM, C3, and C1q, they can add a PLA2R stain. And when they get this pattern, this fine peripheral capillary loop pattern, staining for the antigen PLA2R, they know this is a case of PLA2R-associated membranous nephropathy. The same thing can be done for those cases that are THSD7A positive. This is IgG4 in green, the antigen THSD7A in red, and if you co-localize these two colors, they turn yellow. So again, showing that THSD7A and IgG4 are in the same place in the deposits in this patient with THSD7A-associated disease. So how do we use this knowledge to help us with our patients? I would argue that the first way is in diagnosis of disease, the disease of membranous nephropathy. So the tests we have available are serological tests, taking the patient's blood and asking, are there anti-PLA2R, or, and we have perhaps less experience with the anti-THSD7A, but the same comments I make about PLA2R can go for THSD7A testing as well. So we've used Western blotting in our research. That's impractical for clinical use, but we still use it in the research setting. And the two main tests that are commercially available are a cell-based immunofluorescence assay and an ELISA. And there are several different research tests that are available, but there's one commercial ELISA. There are a few other tests available, a nephelometric assay, a luminescent immunoprecipitation assay, but these are largely in the research setting. Or, as I mentioned, you can stain the biopsy tissue to look for the aggregation of PLA2R into these immune deposits. These are just some schematics I put together about representative ELISAs and the immunofluorescence test. Both rely on having the antigen, PLA2R shown here as red triangles, either at the bottom of the microtiter welt or cells that are transfected either with PLA2R or with a control plasmid. And basically, you're adding patient serum either to the wells or to the slides, asking, are there antibodies that bind PLA2R on the wells or on the cells, and then detecting either with a secondary antibody that has a peroxidase enzyme, and you can do a colorimetric test and compare to a standard curve, or you can ask, you can dilute the patient's serum at different titers and ask, can you detect human IgG stuck to the cells that express PLA2R or not? Both give either quantitative or semi-quantitative values. The ELISA gives strict numerical titers that can be grouped into low, moderate, or high. These were groupings based on a recent review article that I'll mention later in the paper. Or you can titer out the serum and go from 1 to 10, 1 to 32, et cetera, to see sort of a more semi-quantitative view of how strong the autoantibody levels are. It turns out that the slide test, the biochip or immunofluorescence test, is a little more sensitive, so it can pick up values. The range here, anything over 20 is considered positive, between 14 and 20 is borderline positive, and under 14 is considered negative. There are cases where you can detect a value under 14 that would technically be classified as negative by the ELISA that are positive at a dilution of 1 to 10 in the immunofluorescence test. So some centers use both, some use one or the other. I find it helpful when there's a very low titer to try to repeat that in the immunofluorescence test to see if that patient really is truly anti-PLA2R positive. You can take the biopsy tissue, as mentioned, and stain for the antigen PLA2R. This is a case of PLA2R-associated membranous nephropathy. This dull staining is the endogenous PLA2R that doesn't come out as these punctate fine granules. And this would be a case of PLA2R negative, which if you did other stains, such as staining for THSD7A, you may find that this is actually a case of THSD7A-associated membranous. A very intriguing paper came out, and something that we wish we had thought of, but Pierre Ronco in Paris showed that you can clearly have patients who are positive for the antibodies in the serum and positive for the antigen in the biopsy, but you can also find patients who are negative for circulating anti-PLA2R who still have evidence of the antigen in their kidney. So I mentioned that these deposits are very long-lived. So even after a patient clears the circulating antibodies, there can be a historical record of these deposits that lasts for months to years on kidney biopsy. So about a quarter of these cases didn't have circulating anti-PLA2R, but did have evidence of PLA2R-associated disease by biopsy. That's a very important fact that we'll continue to use during this talk. So a group from Nanjing, Chin and colleagues, took their cohort of what was suspected to be autoimmune or primary membranous nephropathy, and they did both the serologic test and they did the biopsy test. They found that about 68% of them were positive for both circulating antibodies and for the antigen on biopsy. But in those patients that were antibody negative, still about 70% of those cases stained positively for PLA2R. So I would argue that most of these patients are over the immunologic phase of disease, but still have these persistent deposits and were still leaking protein. In this cohort, they had a relatively small proportion of THSD7A-associated disease, less than 1%. And there were those patients that weren't positive either for the circulating antibodies or for PLA2R or THSD7A in the deposits. These could be an unidentified antigen in primary disease, or these could be cases of unrecognized secondary disease. For example, someone with an occult malignancy that hasn't yet been detected, some young woman who has early lupus and class 5 lupus nephritis, whose ANA has not yet turned positive. When we think about the biopsy lesion of membranous nephropathy, about 3/4 of those cases, 75%, are primary idiopathic or autoimmune, all meaning the same thing. The majority of the primary cases will be PLA2R. There will be a proportion of THSD7A, and there are probably other antigens that will be discovered in the next few years. In secondary disease, the traditional players that cause secondary membranous nephropathy are class 5 lupus nephritis, hepatitis B infection, the use of non-steroidal anti-inflammatory drugs, certain solid tumors. Mercury is something that has caused membranous nephropathy. We don't see a lot of that anymore. And some other causes, syphilis, HIV, can cause secondary membranous nephropathy. So how do we distinguish a case of primary from secondary disease? And I want you to remember, because this confounds the interpretation of the literature, that the distinction isn't always absolute. Sometimes what may be primary disease can occur coincidentally with other disease processes. I mentioned a case of lupus nephritis where the ANA hasn't turned positive. So you might think this is primary disease when it's actually secondary, or perhaps a patient happens to have a positive ANA and has primary membranous nephropathy. So sometimes it's very difficult to make that distinction. Typically, the tests that we have ordered to look for secondary causes in patients with proteinuria have included the anti-nuclear antibody, the anti-double-stranded DNA, complement C3 and C4 to look for low complement levels, which might be suggestive of a systemic autoimmune disorder like lupus. We measure hepatitis B and hepatitis C serologies, and perhaps we'll go on to check HIV, viral loads, look for syphilis with RPR, anti-treponemal antibodies. But now we have these new tests, anti-PLA2R and anti-THSD7A, that can help us suggest a primary disease. One other technique that's useful when looking at kidney biopsies is to look for the different IgG subclasses within the deposits. This was a study from the Ohio State group, and they looked at the intensity and the presence of the different IgG subclasses in a large number of diseases. And I've only focused here on the primary membranous, the secondary membranous nephropathy, and membranous lupus nephritis. And what I want to point out that in primary disease, IgG4 is usually the predominant subclass. So in this case, 94% of patients had IgG4 with a relatively strong intensity. There may be some IgG1 that can be codominant, but in other cases of secondary disease, IgG4 is less prevalent and usually the intensity is weaker. But IgG1s, 2s, and 3s can be more prominent than IgG4. So this is a way of determining if your patient has primary or secondary disease. Some other things to think about in distinguishing primary from secondary based on the biopsy. In addition to IgG and complement factor 3, which are in all cases of membranous, secondary disease may have IgA, IgM, and C1q. I mentioned the differences in the subclasses. The location of the deposits can be different. Secondary disease may have more mesangial and may have subendothelial deposits. There may be tubulo-reticular inclusion seen in lupus nephritis and in HIV-associated disease. And there have been several studies that have shown infiltrating glomerular immune cells in cases of malignancy-associated secondary disease. So I mentioned a review article, which I find very useful, and I've taken some of their algorithms for this talk. It's done by Anne de Vries from Belgium, the Mayo Group, and Dick Glassick from UCLA. And they've talked about how we might think about using serologies in the diagnosis and monitoring of membranous nephropathy. So this is their diagnosis algorithm. They start with monitoring anti-PLA2R titers and looking for secondary causes. And if a patient has a positive serology for antibodies for PLA2R, has no evidence of secondary disease, they might not even require a kidney biopsy. You can say, based on that information, that they have PLA2R-associated disease. Perhaps if they have declining renal function, you may want to do a biopsy just to see what else might be going on. But some may argue that a biopsy isn't required in this situation. In those patients that don't have anti-PLA2R, a biopsy is probably indicated. If you can stain for the antigen PLA2R, that would be advisable. Looking for IgG subtypes is something that the pathologist could also do. And if you find an IgG4 dominance and PLA2R positivity, that's another indication that this patient has PLA2R-associated disease. Probably immunologically inactive, since the antibodies in the circulation are negative. If they don't stain for PLA2R, but still have IgG4 predominance, then consider staining for the other minor antigen, THSD7A. If you don't find that, then maybe you're dealing with some other form of primary where the antigen is not yet identified. But if you do find either antibodies to THSD7A or the antigen positivity in the biopsy, you can classify that patient as having THSD7A-associated disease. Alternatively, you may find that you don't have either PLA2R or THSD7A and there's a predominance of something other than IgG4, then consider secondary. Now, in the algorithm, the authors argue for aggressive malignancy screening. I think that's reasonable, but I'll give you the reasons for this recommendation. In the initial cohorts by Elian Huxa and colleagues in Hamburg, the proportion of patients who had THSD7A-associated disease and malignancy was higher than expected in membranous nephropathy. So 20 to 30% of these cases were associated with cancer. They also tended to be more female predominant. And in primary membranous nephropathy, it's usually a 2-to-1 male to female ratio. But in this cohort, it was reversed, more females. There's some very good case reports that indicate that certain solid tumors can overexpress the THSD7A antigen and thereby lead to exposure of this protein to the immune system, causing THSC7A disease. So it's definitely worth considering. However, later cohorts that looked at other THSC7A positive membranous patients did not find as high an association with malignancy. But I think it's worth keeping in mind. So consider the possibility. The association of membranous and malignancy may be causal, but it also may be coincidental. Older people get membranous nephropathy, older patients can get cancers. There is this relationship, exactly the strength of the relationship of THSC7A membranous with malignancy still remains to be defined. And clearly, if there's a strong temporal relationship with the tumor and membranous nephropathy, then that's more suggestive of a causal nature. So let's move on. So that was the diagnosis portion. How about disease monitoring and prognosis? And again, I refer you to this excellent proposal for a serology-based approach to membranous nephropathy written by DeVries and colleagues. So one of the reasons it's important to have something other than clinical parameters to follow this disease is that membranous nephropathy is a very slow-moving disease, so the tortoise versus the hare. Something like minimal change disease, which can occur in children, you may have a normal child 1 week, and then the next week the child's complaining of puffiness in the eyes and leg swelling, and you have full-blown nephrotic syndrome in the course of a week. And you may give that patient corticosteroids, and then a week later, the disease is gone. Membranous nephropathy is not that quick. It takes weeks to months for those deposits to build up, and it takes even longer for the deposits to go away. So you can imagine this is the electron micrograph of a patient with membranous nephropathy. To get to these sized electron-dense deposits, one, how long would it take to get to that state? But also, you have this very diseased, sick-looking podocyte. How long would it take for this podocyte to get rid of, to clear these deposits, and to reestablish the interdigitating foot processes that is necessary before the proteinuria goes away? There's some nice natural history studies. This was done by Polanco and Manuel Praga's group in Spain, where they just followed patients with high-level membranous nephropathy, and they didn't treat them with immunosuppression, or some were treated, but 32% of them were allowed to achieve a spontaneous remission. And all these patients went into remission, but it took a lot of time. So the mean time to partial remission, getting below 3.5 grams of proteinuria, was almost 15 months. And those that went on to complete remission took another several years. So it takes a long time for these deposits to go away. If we look at the 10-year follow-up of the Ponticelli regimen, so patients who are treated for 6 months with alternating months of corticosteroids and alkylating agents such as chlorambucil or cyclophosphamide, the treatment itself is only for 6 months, but we see the remission coming out years later. So these are partial and complete remissions, which occur a little earlier, but waiting until a complete remission, complete absence of proteinuria, takes years. So do we need to wait this long to see if our treatments are going to be effective? And finally, going back to the Nanjing study by Chin and colleagues, they grouped their patients into those who had evidence of PLA2R in the biopsy, but no circulating antibody. And even those patients who seemed to be past the immunological phase, cleared their antibodies, it took 18 months for 50% of them to reach a complete remission. If you were unlucky enough to still have the circulating antibodies, it takes even longer for that subgroup of patients to achieve a complete remission. So I like to think about the disease initiation and the end of disease sort of as two different phases. So something starts this autoimmune process. We have some ideas, but we don't know exactly what happens. But in some patients, you get an autoimmune response to this normal protein. Your B cells start making anti-PLA2R. The aggregates form under the podocyte, and the subepithelial deposits get bigger and bigger. There's podocyte damage. There's foot process effacement. And only after you get the damage to the podocytes do you see the proteinuria going up. So the antibodies come first, the proteinuria comes later. At the end of disease, either spontaneously or with immunosuppressive treatment, the antibody levels start to decline and disappear. Until this point, the deposits are still forming, so only when you get rid of the antibodies can you start to resorb these subepithelial deposits. The podocytes can regain very slowly their normal function, and the proteinuria goes down. And this is why we see in curves that look at the probability of achieving remission that the remissions come years after treatment. So how do we come up with these curves? Well, much of this work was based on retrospective work we did with the Mayo Clinic and University of Toronto. Dan Catron and Fernando Fervenza had treated two cohorts of patients with membranous nephropathy with the anti-B cell drug rituximab. And we took the patient's serum at time 0 and out to 24 months, and we assayed by Western blot for the presence of anti-PLA2R. And this is a representative patient. In red is shown the anti-PLA2R levels coming from 100% down to essentially 0. And in blue, the proteinuric response, which lagged by several months behind the antibody level. When we looked at the patients in aggregate, this is anti-PLA2R. It took about 9 months before patients had a complete disappearance of anti-PLA2R. But at 9 months, the patients were still nephrotic, 4 to 5 grams of protein, and the proteinuria continued to drop over the course of the rest of the follow-up. So this leads to this other schematic that I have of immunologic activity measured by serology, measured by detecting anti-PLA2R, shown in red, and the clinical disease activity in the blue dotted line, which lags behind the immunologic activity. And at all these time points, you can say either there's no circulating antibody, there are low levels, there are high levels of anti-PLA2R, and you can also stain the biopsy tissue, which at many time points, once these antibodies start depositing, will be positive for IgG and for the PLA2R. And eventually, the patient will have a decline in proteinuria. They'll either achieve a partial remission with several grams of protein, or they'll go on to a complete remission. The Toronto algorithm was devised by the Toronto Glomerulonephritis Registry that basically was premised upon the fact that patients who have less than 4 grams a day of proteinuria do well. They don't go on to have renal decline, but those that have very heavy proteinuria, greater than 8 grams a day, are the ones that go on and progress to end-stage renal disease. So the goal of this algorithm was to identify and to classify patients into mild, moderate, and heavy proteinuria, and then with conservative therapies, ACE inhibitors, angiotensin receptor blockers, to get those patients, if you could, into this good category of mild proteinuria. If you couldn't, and there are different time windows, 3 months for heavy proteinuria, 6 months for moderate, if you couldn't get them to a good state, that was when you should consider immunosuppression. And the guidelines currently recommend as first-line agents either the cytotoxic corticosteroid alternating months, or alternatively calcineurin inhibitors such as cyclosporin or tacrolimus. These days, we've started using more of the anti-B cell agent rituximab, and there are some other agents that may be useful in membranous nephropathy for immunosuppression. So let's consider a second case in how we might consider titers in deciding whether a patient needs treatment. So this is a 75-year-old female who presents with the nephrotic syndrome, 9 grams of proteinuria, and preserved renal function. Serologies are sent, all of which come back normal, and these include ANAs and complements and hepatitis, etc. All are normal except for an anti-PLA2R titer of 63. She started on renin, angiotensin aldosterone system inhibitors, a loop diuretic, and a statin. And my first question is, does she need a biopsy? And the second is, does she need immunosuppressive treatment? I think the biopsy question, you could argue that maybe she does not. As long as her kidney function is preserved, she has no evidence of secondary causes. You could treat this as presumptive primary membranous nephropathy. The specificity of an anti-PLA2R test that's positive is nearly 100% for the lesion of membranous nephropathy. If you're trying to fine-tune is this primary versus secondary, because of this ambiguity of someone really is the secondary process causing the disease, the specificity falls to sort of the 96-97% range, but it's still a very specific test. The other question is, does she need treatment? Well, it's very difficult to judge based on a single titer. So I say, what if her PLA2R increased, or what if it decreased? So let's look at this on the schematic. So patients who have, so she's starting here at 63. If she goes up into the 190s and the titer's rising when you check it a few months later, I'd argue that she's on the early phase of disease. She's likely to continue to have the antibody levels increase, and she's likely to have a lag, but an increase in proteinuria over time. So in this case, I would consider treating her. If she's on this side of the curve, however, if her titer is falling from 63 downwards, I would argue that she's going into a spontaneous remission and should be continued to be followed and not treated with these toxic immunosuppressive regimens. This leads us to prognosis, and as I said, it's difficult to prognosticate based on a single value, but those papers that have shown looking at tertiles and the highest tertile of anti-PLA2R versus a middle tertile or a low tertile tend to suggest that those that have the highest levels are the least likely to achieve a spontaneous remission and are more likely to go on to double their serum creatinine. That's because high values tend to be in the midst of disease, and it's going to take a long time both to get rid of the antibody levels and to have a consequent drop in proteinuria. Patients with low levels, they could be on this side of the curve, but we tend to miss patients early because this disease develops so slowly. So when we find low levels, they've often run the course already, and they're much closer to immunological remission and consequently clinical remission as well. So these patients tend to do better. The DeVries proposal on the use of serology also has an algorithm for how we might use titers. They suggest measuring the titer. If you have a high level, follow it more regularly. I don't know if monthly is necessary. You can use your clinical discretion. If the titers are going down and they go down to a moderate or low level, you can continue to follow. If the patient's nephrotic but having declining titer, you can continue to follow until the patient has an immunological remission, undetectable anti-PLA2R, or has a remission of proteinuria. Similar, if the patient is non-nephrotic, you can just follow the titer. That's opposed to patients who have increased or stable high titers. Those are the ones you might consider starting immunosuppression. In this algorithm, they actually suggest that if a patient has non-nephrotic range proteinuria but having increasing titer, you should start immunosuppression. I would recommend using your clinical discretion here because these regimens are toxic in some cases. They all have different adverse effects. And non-nephrotic range proteinuria isn't inherently dangerous. If it continues and it has persistent nephrotic range, then I'd be worried. So I would be more apt to follow these patients and not immediately start immunosuppression. These are some examples from the Hamburg group, and they show the same principle of patients treated not with rituximab, but with the first-line agents, alkylating agents, or calcineurin inhibitors. And what I want to point out is with calcineurin inhibitors, the patients attain their lowest anti-PLA2R levels by about 6 months. There's a lot of sort of bouncing around after that, which shows to me that calcineurin inhibitors aren't the most effective. But many patients get to their nadir level by 6 months, and at 6 months you still have 5 to 6 grams of protein that continues to fall. Similarly, with alkylating agents, most patients tend to have undetectable anti-PLA2R by 3 months, which is very stable afterwards. And at this 3-month point, the patients have 7 to 8 grams of proteinuria that falls afterwards. So we're looking first for a fall in anti-PLA2R, and then would expect a drop in proteinuria after that. So what happens if I treat a patient and I can't fully suppress the autoantibodies? Well, there's some nice studies, and this is a retrospective analysis of 2 studies done by the Jack Wetzel's group in the Netherlands. They had patients either treated with cyclophosphamide or mycophenolate, and all of their patients in this graph were positive for anti-PLA2R at the start of treatment. And what they asked is, did the treatment regimen at the end of the treatment cause the patients to go into an immunological remission where anti-PLA2R was negative, or were the antibodies still positive? In those that were still positive at the end of treatment, all of those patients relapsed in the first 2 years. So all 9 patients had an early relapse. Those patients that you treated from positive to negative, most of those remained in remission, and the relapse rates were similar to what you might expect for even the best treatment with the Ponticelli alkylating agent corticosteroid alternating regime. So it's important to treat to anti-PLA2R negativity. Another study done by the Bergamo group with Ruginenti and Ramuzzi showed in patients treated with rituximab, all of them had effective depletion of B cells, no matter whether or not they achieved remission or not. But those patients that had a drop and a stable decrease in anti-PLA2R, those are the ones that had the complete remissions or achieved the combined endpoint of complete or partial remission. If you had a drop in your PLA2R, but then it didn't continue to go down and remain detectable, these were the patients that did not have a remission of their clinical disease. Oops, let me go back. So I think using antibody titers to monitor response to therapy and when we can stop therapy is still in its infancy. We definitely need more data on this. The algorithm proposed by De Vries et al. Suggests that, let me start on the other side. If there's a decrease in antibody titer by 6 months, to continue the therapy. It appears to be working. If you can't achieve less than a 50% reduction by 6 months, then maybe consider changing your immunosuppressive agent. They suggest that if you get a rapid response greater than 90% decrease in anti-PLA2R, that you can consider stopping therapy. I've certainly had patients who had a very large drop who then rebounded. So I think you can consider this, but I would recommend trying to treat to an undetectable anti-PLA2R level. And whether you use the recommended threshold of 14, below which is a negative test, I tend to use an even lower value, and there's some papers coming out that suggest a level of 2.6 might be a better threshold. I think I would continue immunosuppressive therapy until the patient have undetectable levels. So in summary, and I have one more section after this, using anti-PLA2R, and by extension, we can think about using anti-THSC7A the same way, that these antibodies reflect a potentially useful biomarker that we can measure the immunologic activity of primary membranous nephropathy. This is because there's a remarkably consistent relationship between the immunologic disease activity reflected by the serology of anti-PLA2R and clinical disease activity. Higher levels of anti-PLA2R at baseline tend to portend a longer course of clinical disease and longer times to remission, which potentially can have adverse renal consequences like end-stage renal disease or doubling of creatinine. And the continued presence of anti-PLA2R at the end of a scheduled therapy is associated with a higher rate of clinical relapse. So one final case of another application of these tests. So your patient didn't do well, didn't respond to therapy, and has progressed to end-stage renal disease due to PLA2R-associated membranous nephropathy, and is now being considered for a living donor kidney transplant. You test this patient, and there are still circulating anti-PLA2R antibodies that are positive. So the question is, should you go through with this transplantation? Will this disease recur? So recurrent membranous nephropathy is a problem in patients who have had membranous nephropathy in their native kidneys. The rates of recurrence range from 10 to 45%. Those centers that do a protocol biopsy at a month or so tend to find it earlier and have a higher incidence. If you wait for the clinical manifestations of proteinuria, the mean time for an overt recurrence is about a year after a transplantation. We know that you can find anti-PLA2R associated with recurrent membranous. There's another type of membranous nephropathy called de novo membranous nephropathy that occurs in patients who haven't necessarily had membranous as their primary renal disease. This tends to be associated with chronic allograft rejection and humoral rejection. This type of disease is not associated with anti-PLA2R. And the question is, does the presence of anti-PLA2R at the time of transplant predict a recurrence? So we looked at this with the Mayo group and their recurrent membranous nephropathy cohort. More technically, their patients who had membranous nephropathy in their native kidneys and then had a transplant. And we tested whether pre-transplant anti-PLA2R was predictive of recurrence. It turned out to be not a wonderful test, but an instructive test in that 83% of those, so 10 of 12 who had positive titers, did have a recurrence. Of those who were negative, there was still 58% recurrence. So the negative predictive value isn't very useful. This cohort of patients did have protocol biopsies, so perhaps the recurrence rate was higher than you might have gotten at a center that doesn't do this early testing, because you can find these very tiny deposits that may not have become clinically significant. Thinking about the negative patients, we don't know if these patients had PLA2R-associated disease in their native kidney. So maybe there was a THSD7A-associated disease that had circulating antibodies to that antigen, but tested negative for anti-PLA2R. So we have to take these in context and think about them. But in general, there are a number of studies out there, and basically the conclusion I draw is those patients that have higher levels of antibody in the pre-transplant period are more likely to have a recurrence that's clinically significant. Schematically, you can think of it like this. So if you go into transplantation with some level of anti-PLA2R and get a new kidney, these patients are put on a lot of immunosuppression, often prednisone, often calcineurin inhibitors, often antimetabolites like mycophenolate. So that in itself is enough in some patients to cause a decline in disappearance of the anti-PLA2R. So maybe they'll have tiny deposits forming, and if you do a protocol biopsy, you'll find it. Maybe there's a blip of proteinuria that otherwise would be clinically insignificant. As immunosuppression is weaned years later, some of these patients do have a later relapse where the anti-PLA2R levels go up and there's a overt clinical recurrence. Compare that to a patient who goes in with a higher level of anti-PLA2R, gets transplantation, and some of these patients just don't respond to the immunosuppression in that the anti-PLA2R remains stable or even increases. These are the ones that have the persistent aggregation of these immune deposits, that have worsening and worsening glomerular damage and become proteinuric early and go on to an overt recurrence. These often need treatment with anti-B cell agents like rituximab. So to summarize recurrent disease, the positive predictive value and the negative predictive value of a single test are poor. And it's important to know if a patient has had PLA2R-associated disease in the native kidney, because in that manner, a negative test at transplantation is more reassuring. I would argue that having a positive serology at transplantation should not affect the decision, because many of these patients, just with the transplant immunosuppression, will go into remission. But it is important in these patients to have heightened surveillance for proteinuria and to follow levels of anti-PLA2R. If the levels are declining, that's good. But if the levels are persistent or increasing, then consider biopsying that patient and or treating with rituximab. So finally, the take-home points are that we have two antigens now, PLA2R and THSD7A, are the respective major and minor autoantigens in primary membranous nephropathy. Circulating antibodies to these podocyte proteins or the finding of enrichment of these antigens within the deposits is highly suggestive of primary disease. I've shown there's a consistent relationship between the immunologic activity as measured by antibody levels and the clinical course of disease. And due to the slow onset of disease and the slow time to remission, that monitoring these autoantibody levels has emerged as an adjunctive and quicker method that we can follow disease course and monitor response to treatment. So when should we consider testing for anti-PLA2R? Because this is the major autoantigen, I would suggest that in any patient who has unexplained proteinuria, especially when you have nephrotic syndrome, consider sending this in your panel of ANAs, complement tests, hepatitis serologies, RPR, etc. I think it's even more helpful in a patient who's known to have PLA2R-associated disease, either by the basis of a positive serology or the presence of the PLA2R on biopsy, because you can follow the trajectory of disease. Are the antibodies increasing, decreasing, which can help guide initiation, duration, or change in immunosuppression. If a patient does relapse, it's worth rechecking the antibody levels to see if there's truly an immunologic reason for that. And as I mentioned before, and if positive after kidney transplantation, is a useful time period. Anti-THSD7A antibodies, I believe that the immunofluorescence slide test is available, but not an ELISA yet. Because of the low prevalence, I wouldn't recommend screening all proteinuric patients for this. It's a very low yield. But if a patient has membranous nephropathy, that's negative for PLA2R, consider staining the biopsy for THSC7A and consider measuring anti-THSC7A antibody levels. And if you know a patient is THSC7A associated membranous, just like we use the anti-PLA2R serologies, we can use anti-THSC7A to guide treatment, to look for relapses, and to see what happens peri-transplantation. So that's it I have for the slides. I'd now like to open this up for a question and answer session. And thank you for your attention, and I look forward to speaking with some of you or answering your questions.
Thank you so much, Dr. Beck, for this very, very insightful presentation from a research, laboratory, but also nephrologist perspective. I appreciate very much, and yeah, let's move on to the questions of the audience.
All right, perfect. The first question is regarding the gap in supposedly primary membranous nephropathy cases. There's still a gap between those that were clearly identified to be primary or idiopathic, and on the other hand, really had a clear secondary cause, and this gap potentially being primary. Do you think from a clinical perspective that this is first and foremost a lack of identifying the secondary cause of the disease, or how much room do you think is there left for autoantigens that can be identified as the actual primary cause of the disease?
Right. I think there's probably a mix of both. It is a difficult subject when we think about either secondary cases by virtue of, say, a positive ANA or hepatitis serologies that have anti-PLA2R, but I think on the other hand, those cases that really have neither the PLA2R or THSD7A antigens, but no secondary cause has been found. I do think there are other primary antigens out there that are remaining to be identified, but I also think that we probably miss some secondary cases. For example, I mentioned the young woman who hasn't yet turned ANA positive but has features of a secondary membranous nephropathy, for example, subendothelial and mesangial deposits, and may later in life, develop other symptoms of lupus. So maybe the lupus nephritis is the first manifestation. And certainly there are probably occult malignancies that have yet to be discovered. So that's why I think a biopsy may be important in these cases, because there may be other features, IgG subclasses, the location of the deposits, tubulo-reticular inclusions that may give you a hint that maybe there's a secondary cause, versus having IgG4, which as the predominant subclass, which may suggest that this really is another primary disease and we just don't know what the antigen is.
Okay, thank you very much. Maybe a second question, and in the interest of time, maybe the last one as well. The usage of THSD7A, with you being at the forefront of the clinical setting, but also the research setting, you think of THSD7A as a potential extension of the body of knowledge that we've already built around PLA2R. Do you see those parallels also in a clinical practice with the patients you investigate in your studies and from a physician standpoint?
Yes, and I think the problem is, of course, that as 3% of primary membranous nephropathy, we haven't had a lot of patients, and having just identified this in 2014, we're still accumulating the clinical experience. But in my practice, we have had a few, both at my center and sent to me for reference laboratory testing, not reference, just research laboratory testing, and we do see that the antibodies are present in the nephrotic state, and with treatment they tend to go down and disappear. I think we have fewer data on relapse, but I think there is evidence in the literature that a patient who had THSD7A associated disease and relapses can go from a negative serology to a positive. So I think as more cases develop, as we see more research publications on this, we will gain more experience, and I do expect that the lag time between immunologic disease and clinical disease will follow the same pattern as anti-PLA2R.
Perfect. Well, thank you so very much, Dr. Beck. I personally find this topic to be very, very interesting and rapidly developing, so I think keeps everyone busy with research. I really like that topic. I really, really appreciate you taking the time for this webinar today. Thank you so very much for all the participants during this session.